So hello to everyone. I'm Fabio Taccone from Brussels, and I have the pleasure today to chair an interview a very distinguished speaker, Jerry Nolan from UK. I'm sitting in the office of Jean-Louis Vincent. That's very important issues for the others, because you will recognize this office from the two previous chats. This is our third chat of ISICEM. So Jerry, really pleasure to see you. Can you just introduce yourself for our audience?
Of course, Fabio, it's a great pleasure, and thank you very much for giving me this opportunity. So I'm Jerry Nolan. I'm a consultant in anaesthesia and critical care medicine at the Royal United Hospital in Bath, and I had a long-standing interest in various issues relating to resuscitation, and most recently was chair of the European Resuscitation Council until about 4 weeks ago.
So it's with the new year, you maybe have a new function now in the resuscitation community.
I might be able to relax a bit more.
Exactly. So, Jerry, the topic of the chat today will a little bit around the cardiac arrest center, and you know the idea was coming from this paper. We'll talk about that disposition paper of different society discussing the issues of cardiac arrest. So, can you tell us what is a cardiac arrest center first?
Well, as ever, of course, you start with perhaps one of the most difficult questions of all, because the actual definition of a cardiac arrest center is really quite controversial. In fact, as we discuss the forthcoming ERC and ISICEM guidelines coming out, there's already controversy from some of the peer review coming in about that paper. But I think broadly, my interpretation of what a cardiac arrest center is that it's a center that sits within a system of care for out-of-hospital cardiac arrest. And I think it's really important to put that up front. It's not just about the hospital or the center itself, it's about a system of care. And it's a center where typically they will see generally a fairly high volume of out-of-hospital cardiac arrest patients. We can discuss numbers perhaps a little bit later on. But I think the focus, the one thing that seems to be consistent in pretty well all definitions you will see, is access 24/7 to urgent coronary catheterization. I think that becomes the sort of central point of it, but it's by no means the only aspect, I think, of a cardiac arrest center. I think it's important that urgent catheterization laboratory is supported by an intensive care that's capable of providing all the treatments that would be needed for an out-of-hospital cardiac arrest patient. And that would include, of course, temperature control, TTM, as well as the neurological facilities to back that up as well.
It's of course, as you said, the very controversial issues. Can you tell us if your setting is a setting where you have a cardiac arrest centers compared to the other situations?
Yeah, no, in fact, it's helpful to describe my setting, because unusually, actually, I don't work in a hospital that probably in many places would be regarded as a cardiac arrest center, and yet I'm working within a region of the United Kingdom that by default has become regionalized in the way that it treats its out-of-hospital cardiac arrest centers. So I work in a hospital that's just 10 miles away from a much bigger hospital in Bristol. That hospital in Bristol's admits to its intensive care unit 160 out-of-hospital cardiac arrests a year. It has a 24/7 cardiac catheterization facility there, and it pretty well meets most of the criteria that have been described for a cardiac arrest center. On the other hand, the hospital I work at is still a large hospital, 700-bed community, standard general hospital, with a cath lab that's available for most of the days of the week, but not in the middle of the night. So it's a complex arrangement. So to give you an example, we will see patients out of hospital cardiac arrest who get resuscitated, who will bypass my hospital, particularly at night time and during the weekend, to go to that hospital in Bristol. So you can see already the start of a regionalized system there. Probably a better example within the UK is in London, where they have they clearly have 7 what are actually called heart attack centres, but really are cardiac arrest centres, and they will focus a lot of their out-of-hospital cardiac arrest on those hospitals.
I have 2 other questions for this. It's a first part. The first question is, in the paper that you have been co-authors about, this position paper about cardiac arrest centres, you also even more complexify the issue, because you discuss about cardiac arrest centers, as you said, but you also discuss about an hub center on top of the cardiac arrest, which is even more hierarchical organization. Can you tell us a little bit whether, which is the reasons why you should have a hub center, and whether this hub center already exists in some specific settings?
Well, you can imagine this position paper, by the way, involves a number of European organisations, and although it was led by the acute cardiovascular care section of the European Society of Cardiology, a number of other organisations were involved, as you know, including, of course, European Society of Intensive Care Medicine. As ever, whenever you talk about something to do with regionalisation, there are all sorts of geographical and political elements that come into play, and to try and get consensus amongst a large number of European organisations about how to define a cardiac arrest centre was very challenging indeed. So the concept of this paper was to come up with something where you would have potentially hospitals that would be defined as a cardiac arrest centre, but sitting over that in very large regions, maybe these so-called hub centres that provide maybe some extra things on top. Now, those elements might, for example, be in that system, the provision of extracorporeal CPR, re-CPR, for example. It may be providing a significant education and research facility that would not necessarily be available at some of those other hospitals. But I think it's really important to point out that it's going to vary quite considerably depending on the country that you're in and in the region you're in. And the American Heart Association, for example, have produced their document on systems of care for out-of-hospital cardiac arrest that describes yet another type of system. So there are many different models that are out there. And I think you have to adapt to your particular local needs, really, to come up with the best model for you.
Yeah, of course. That's as you said, it's really controversial, although if I'm not wrong, of course, the idea of a cardiac arrest centers already exists since a few years. But as you said, position papers still delicate sometimes also to implement in clinical practice. Of course, now you have told us which is a cardiac arrest center. And now the question is, do we need a cardiac arrest center? Maybe you can start from what the guidelines will tell us with the new recommendation of this year. And what is your opinion about that? Should we really need a cardiac arrest center everywhere?
Well, I think there's no doubt that the general thrust of the recommendations that will come out later this year will be that where possible and where the systems exist, we should be aiming to transport out-of-hospital cardiac arrest to a cardiac arrest centre. That's a very broad statement because that's a sweeping statement that could therefore include all out-of-hospital cardiac arrests. Others would argue that it should only be cardiac arrest of cardiac cause, for example, although that's sometimes difficult to distinguish. But I think the thrust of it is that, yes, the recommendation is we should be driving towards cardiac arrest centres. Do we have evidence to support that? Well, there's been quite a good systematic review that was published in 2019 on behalf of ILCOR, looking at all the studies out there. And I think they managed to find 22 studies that were looking at this whole concept of cardiac arrest centres or regionalised care. But only one of those was a randomised controlled trial, and that was only a feasibility trial. And in fact, let's talk about that more later on, but that is a trial that's ongoing in London at the moment. The others are all observational studies, and they were able to kind of meta-analyse, I think, 17 of those studies. They're all obviously open to considerable bias, and it's really difficult to interpret that. And in fact, even the results of that meta-analysis were conflicting. There was evidence to suggest on some of those studies that there was an improvement in survival at hospital discharge and even survival CPC1-2, neurologically favourable survival. But yet, when you look at the studies that looked at 30 days survival, there was no significant difference. So it's really quite hard to tease out the evidence for improvement in outcome. I think it's really important, though, that we draw parallels with other regionalised systems of care. And I think few people would now argue against trauma care, for example, being regionalised. And you could argue that this is a very, very similar arrangement.
Yeah, of course, let's be provocative, of course, because we discussed today, I like cardiac arrest too, and I'm also in favor of the idea of a centralized, of course, care. But people would say, okay, if you say that we need a cardiac arrest centers and this cardiac arrest center organization would also improve patients' outcome, is this because in non-cardiac arrest center, they not comply with guidelines? They maybe just provide, not an adequate care. So it's just a matter of teach these people how to do it. So we don't need a center, we need to teach more. And the other question would be, are we really sure that just complete to guidelines will be enough? Because we have very few randomized clinical trials in the in-hospital management of cardiac arrest, of high quality of care, to really change the outcome of the patient. So even if you apply guidelines, how these guidelines, based on many observational studies, most will really change the patient's outcome.
Yeah, no, I agree. I think it's very difficult. There are very, very few interventions, as you know, that are really underpinned with randomized controlled trials. And even, dare I say, TTM, of course, which most people would regard as perhaps supported by the highest level of evidence, is still, some people would say, is still controversial. And we await the results of TTM2, as you know. So I think it's really difficult to prove that those centres that perhaps don't have the same outcomes are getting those outcomes because they're not applying guidelines. I don't think we can prove that. I think we can look at volume effects, and I mentioned earlier on that maybe the sheer fact that you're looking after large numbers of these patients means that you and your team and your system gains the experience in dealing with them. And I think there are subtle aspects that are difficult to study. For example, in a so-called cardiac arrest centre with high volumes, I suspect that on average you will have very good access to neurological investigations, for example, and some of the prognostication that goes on in a cardiac arrest centre may be different to some of the smaller hospitals that don't have the experience. In other words, it might be cardiac arrest centres are actually keeping these patients comatose, but keeping longer and trying harder to see whether they do actually awaken and make a good outcome. And I think that could be true of other things as well. I mean, do the cardiologists have the same level of experience in a smaller centre? In my view, in some cases at least, I'm aware that in the big centres, the cardiologists, the interventional cardiologists in particular, are perhaps more aggressive in the way that they treat these comatose patients. In other centres, they will say, look, well, we want to wait and see before we go in. So I think it's pretty difficult to tease those elements out.
Yeah, you're right. And there is also another issue I think is very relevant, because when we talk about center, we think about the hospital as a building. So it's a really clear place where people are admitted. But as we know already from the chain of survival, of course, if you want this cardiac arrest center to be effective, you should work, I suppose, in close contact with the pre-hospital care. Yeah. And if I look even longer, you should have within this center a rehabilitation center where these people could be evaluated after, of course, ICU and hospital discharge, even for long-term neurological sequelae or re-education. So maybe this cardiac arrest center for many people is just a building where you admit in the early phase these patients, but it's a more wider organization in terms of people that are involved.
Yeah, Fabio, that's a really important point, very important. I mean, perhaps depressingly, I have to say that the community, the quality of the community response, those early phases in the chain of survival, will have far greater impact on the quality or the chances of somebody surviving and the quality of their survival than any intervention that we do in hospital. And I think we have to recognise and accept that. So these so-called cardiac arrest centres must integrate and work very closely with the community response and be involved in research and education to develop that. And as you mentioned, at the other end of that chain of survival, rehabilitation is notoriously poor in many countries for these cardiac arrest patients. I think patients that have acute myocardial infarction without cardiac arrest probably do very well for rehabilitation. They get good quality cardiac rehab in many countries of the world. Yet if you are recovering from being comatose from after a hospital cardiac arrest, the quality of your rehabilitation you get through your neurological issues and cognitive issues is really not very good in most centres.
There is another, I think, question, because we are already touching different issues, but of course, in the idea of cardiac arrest, you mentioned during one of your explanation, out-of-hospital cardiac arrest are managed and admitted to the hospital. Of course, the question would be, what would happen for in-hospital cardiac arrest? We know that these are different causes of arrest, but still these patients suffer from the post-resuscitation syndrome and post-anoxic brain injury. What would happen? Should we transfer also in-hospital cardiac arrest to these specialized centers, or in-hospital cardiac arrest, you think it's a different issue?
Okay, so that I think is one of the great challenges of regionalizing a system like cardiac arrest care, because it may be that you do improve the treatment and outcome of patients for out-of-hospital cardiac arrest, but with the potential risk of deterioration in the quality of care for those patients that have an in-hospital cardiac arrest. And that's purely because those centers that are keeping their in-hospital cardiac arrest do not have the experience in managing as you say, the post-cardiac arrest syndrome and all the consequences of that. So the question, should we be transferring those patients? I think that's going to come down to differences in different countries and different systems. I suspect ultimately the answer to that is potentially yes. And I hesitate to say that because I can imagine the politics of this and the volume of patients, going into some of these centers could be potentially huge. But I do think there's a lot of common ground in the way that we manage the post in-hospital cardiac arrest patient as there is for out-of-hospital cardiac arrest. So eventually, I think the short answer to your question is we probably should be looking at regionalizing the care of those patients as well. I think that may start to happen naturally. I don't think that's something we can force. I think we should just see how things evolve.
I really thank, because I think your explanation a lot of good sense, but also we can see the experience of a long discussion probably had during the different guidelines meetings. Yeah. I would like maybe to close this very nice chat with the last question, maybe the summary of what we said. Do you think that in the future, in this chain of survival, we will see a symbol representing a cardiac arrest center coming out?
Yeah, I think we'll see a symbol of systems of care and some sort of center at the, some sort of hospital at the center of that. Whether we would still call that a cardiac arrest center or some other term, I don't know. I suspect that we will basically see that incorporated into the chain of survival. Quite how we do that graphically will require lots and lots of meetings and discussion.
Thanks a lot. Thanks to Jerry. Thanks for your nice and very clear participation. I am sure that all our audience will enjoy this nice discussion. And of course, I thank ISICEM for the organization and all the people who will listen to this video. Thanks a lot.
Fabio. It's a great pleasure. Thank you.
Bye-bye.
Take care.